Hello and welcome to Business on the Wire. I'm Mitali Mukherjee. Amidst the gloom and despair that COVID has brought on our lives, there is a ray of hope that's coming from the world of medical research in another area. Singaporean molecular diagnostic company Tzar Labs, in collaboration with India-based Epigeneres Biotechnology, has developed a new blood-based test that can be used for early cancer prognosis and diagnosis. The discovery itself lies within a more contentious segment of cellular biology, but the potential, if this does indeed scale up globally and locally, is enormous. It also has vast market potential for itself within the diagnostics world. Joining me to talk about that is Ashish Tripathi, Chief Executive Officer at Tzar Labs Pte Ltd. Remember, this is not just a problem that any one nation is living with. At last count, in terms of data, the numbers that came in for cancer in India are estimated at 13.9 lakh in 2020, and that could scale up to 15.7 lakh by 2025. That's some of the data that ICMR, in partnership with other cancer research institutes, published just last year. Ashish, thank you for joining in. This is seen as the first prognostic test for cancer in the world. I cannot claim to know a whole lot about the subject, but what I read in terms of your findings were absolutely fascinating. So I want you to first walk someone who's watching this conversation through in terms of what it is that you have found and how your test will work.
Thank you for having me. If I can just give you a little bit of a background, there are some very major companies, especially from the US, that have been working on an early diagnostic test for cancer. And their competitors who we respect a lot. The process that all of them have been taking, or the method that they have been using, is they are essentially looking at pieces of tumor in your blood that are circulating in the blood, whether it is CTCs, whether it's cell-free RNA, or whether it's cell-free DNA, right? Now, the challenge is that when you take, about 1.1% of your blood, that's how much you draw out, right? And if you can see the tumor pieces, you know that this person has cancer. But if you don't see the tumor pieces, that does not mean that you don't have cancer. It just means that in the sample set that you got, there was no tumor, right? Our methodology is essentially very, very different because we get a marker for when there is cancer, and we get a reading when there is no cancer, right? So there's a fundamental difference in approach. They are looking at a resultant marker. We are looking at a causative marker, and that has shown up in the results because our accuracy, or our specificity, as it would technically be referred to, is quite high compared to their methodology. And in essence, our breakthrough is around isolating a certain set of cells for the very first time in blood, in peripheral blood, and then understanding the implication of this with cancer, and also its interrelationship with some other cells in the body. And on the basis of which we were able to make a specific Hrc score, which is working extremely accurately as a as a marker for cancer.
I want to get into some more specifics of
that's in this.
Yeah, I want to get into some more specifics of the test, Ashish, before we talk a little bit more about the process that you just outlined in some detail. This is going to be a blood test, first of all. You also indicate that it can cover almost 25 types of cancer. And interestingly, you've made the comment that this is not just detection of early stage cancer, but also your proclivity to it. The fact that you may get it, or the fact that you won't get it this year and you won't get it next year either. How does that work?
So, Mitali, firstly, let me just clarify. The headline is that it works on 25 different cancers. But when oncologists look at the data, what they are fascinated by is that this is working on solid cancers. This is working on blood cancers. It is working on sarcomas, right? So it is working across different classes of cancer, if you will, right? Now, the reason we are able to actually make such a broad claim is because, unlike the tumor-based approach, which I mentioned earlier, you see, what they do is that they look at the absence of the tumor as indicative of non-cancer, which is why they get so many false negatives, right? Because it's a difference in approach. Our marker is very unique because it actually gives us the entire spectrum of the disease. It gives you a reading for all stages of cancer, for all types of cancer. But at the same time, it also gives you a reading for all types of non-cancer. So we can in fact tell you when you are within a safe zone, because even see, what we are essentially measuring are these biomarkers that are indicative of the different types of cancer. So when you're within the safe zone on this HRC reading, right, we not only know that you don't have cancer, we know that you cannot get cancer for the next year because there is a certain pace of growth of these markers, and how they progress. So when you're within the safe zone, we can actually act as a prognostic test that tells you that you don't have risk of cancer for the next year, right? And what it also does is that it actually tells you when you're at imminent risk of cancer. And while there is another clinical study on, which is why we have not spoken or talked too much about this, but at that stage prior to tumor formation, we can actually tell you which cancer and where it is growing in your body straight from a blood test, right? And that is what makes this marker because if you look at cancer, the challenge with cancer is that you're not aware of the disease till it's late, right? Because it leaves very few signals, right? And in essence, what we are trying to do is we are essentially, right, trying to make sure that we can increase or improve detection technologies, which is going to actually help oncologists who are really the true warriors, right? As far as this disease is concerned.
Okay, let's talk for a little bit, Ashish, about the kind of cells that are being used for this particular blood test that you have zeroed it down to, which is the VSCLs, the very small embryonic-like stem cells. Uh, there is some debate around isolating this, around identifying this. How do you negotiate or navigate the concerns around isolating it? And why is it that you have such deep belief in the VSCLs themselves? As you pointed out yourself, for the current existing organizations, I think mostly US based, that's not the technology that they're using at all. That's not the methodology they're using at all.
So let me explain that. Actually, this is not a new cell. Frankly, we never found the cell, right? A very respected scientist from the US found it in 2006. Found these cells in 2006. It has been extensively studied in over 40 institutions, right? And you're very right that there is debate, right? But there are institutions from around the world that have actually confirmed what the nature of the cell is. There's been a significant amount of studies done on this as well, right? Our only breakthrough is that we figured out how to isolate it in peripheral blood,
Okay.
right? Or in blood samples that you draw from your body, right? But there is a significant amount of data and science available on the nature of these cells. We can actually, I mean, we've got images of these cells, right, that we can actually show. We know what the essential, unique markers for these cells are, right? And we've already tested these cells for that. That said, as a company, our breakthrough is around a specific marker that we are getting from these cells, right? So even while the debate rages on, we are convinced that these cells exist, and there are many scientists around the world that these cells, who are convinced that these cells exist. But the point of the matter is, what matters is the markers that we are actually getting from some of these cells, right? And the algorithm that we are actually creating as a result. Now, when you do a blinded trial of 1,000 samples, right, and you're able to show that it has worked on all these samples, right, there will be a degree of confidence, right, in our methodology, or at least we have in our methodology. We are also going to do global studies, and by the time we complete those studies, we're convinced that there's not going to be any debate around the existence of these cells. But that said, in science, there's always debate, and there are vested interests that actually have views on different positions, and that debate will continue. That does not take away from our methodology or the process that we have actually followed.
Yeah, that's just the point I was coming to, in fact, Ashish, because the same scientist who did discover this in the first place has put that out as 2 points of defense. One, the fact that people have been unable to successfully isolate a VACL. And secondly, that there are perhaps vested interests for people looking at other forms of stem cell technology. Are you worried about facing pushback on that front? In terms of people questioning you because there are, as you said, vested interests, or the fact that there's more money and more R&D pushing a different form of study?
Yeah. So look, once again, what I'm saying is that we as a company, our philosophy is we didn't go public with our science, we didn't go public with our story until we had actually got this published in a very respected journal, right? So this is actually a Springer Nature publication, as you know, and the reality is that we have actually spoken to experts from around the world, right, that have and there are certain, the whole reason you put the science out is because labs from around the world can now test, right, our methodology, right? And we believe that we've developed a very robust methodology for you to be able to analyze this, right? But once you have actually gone public with your technologies, the reality is that's the time when the debate will actually start to end, because the reality is that there will be labs from other parts of the world that will actually confirm, right, whether they can actually see this. At the end of the day, these are cells that you can actually that you can see under a microscope, right? So the way we see it is that that debate will end. But Dr. Ratzak, by the way, very much believes in these cells and the science. We have spoken with him. We've spoken to our own scientists from ICMR who've actually researched this for decades, and we remain extremely confident of our methodology. Let me clarify one thing though, Mitali. The reality is that, what we have done is we've used these cells and we've applied, certain methodologies to create a marker, right? And what the world is going to test is whether that marker is working. The debate on the underlying cells, etc., can continue. The reality is ultimately what's going to matter is that marker working or not? And we are pretty confident of our methodology. With that kind of specificity, one has to be very confident about how well this particular marker is working.
So let me delve deeper into the point that you're making about the marker and go back to the trials that you conducted. 1,000 double-blinded clinical trial. I understand 500 of those who were being tested were cancer positive and 500 were not. What did you find? What kind of gradation do you see on the marker? And were you taken aback by the results? When you come out with a 99.9% accuracy, that's a stunning reading. Did you guys sit back and say, "Whoa, this is really something"?
So, the breakthrough was when we were able to isolate these cells, right? Let me just for your audience, let me just explain how HRC works. HRC is a transcriptomic marker that feeds into an algorithm, which actually gives you a score. When we take your blood sample, I can give you an HRC score. Right? Now, the way the HRC score works is that you get a reading anywhere between 0 and 60, right? Now, if I was to take your blood sample or my blood sample, we would typically sit in the 0 to 2 range on this marker, right? And what that indicates is that we don't have cancer, but more importantly, we don't have risk of cancer for the next 1 year, because even the fastest moving cancers cannot go from 2 to 10, which is when stage 1 starts, right? Now, these markers also indicate when there are certain inflammations that are happening in the body, right? It gives us a reading in the 2 to 6 range. You're still healthy, right? So we consider 0 to 6, right, to be healthy patients, right? But the point is that there is something that is actually, impacting certain organs in your body, right? The 6 to 10 range is actually the most insightful range on this marker, because this is actually indicative of there are certain mutations that have happened in tissues in your body, right, which are indicative of cancer. It could be in any part of your body, right? And we are able to do a follow-on study and actually figure out where these mutations are taking place, even at that stage, right? And 10 to 20 is stage 1, 20 to 30 is stage 2, 30 to 40 is stage 3, and 40 plus is stage 4, right? So look at the value of this marker. Not only is it with one reading telling you what stage of cancer you're at, it is actually telling you all the stages of non-cancer, right? Now, one other point that I want you to understand is what is the nature of the disease of cancer, right? So when you're looking at a small tumor, you're basically talking about 100 million cells of cancer coming together and forming a mothership, right? Now, once the tumor forms, this is a dangerous disease because it starts shedding a lot of CTCs, especially when it matures, right? And that's how it spreads so quickly. But the point of the matter is you don't get 100 million cells of cancer coming together, right? Yesterday you didn't have it and today you do. That's not how it happens, right? It happens through a slow progression. Why is a tumor formation actually seen as the marker for when you have cancer? Because when you do a PET scan, right, when the tumor size is too small, it is not detectable, right, in your PET scan, right? So that is a constraint of measurement. It's not a constraint of detection. It's not a constraint of the disease. The disease is forming. What we can do is actually tell you when that tumor is forming, right? And before it has reached that tumor, that critical size, when it is detected on a PET scan, right? And that is our breakthrough, right? So, and the point is that what conventionally everyone knows is that if you can catch the disease early, right, you can significantly increase survival rates for patients, right? So what we are trying to do is we're trying to actually make this disease into an earlier stage disease than what was known to date, right? This does not take away from the detection abilities of this particular technology as well, because it can still detect stage 1, stage 2, stage 3, stage 4. So it is actually from a non-invasive marker, right, from a blood test, actually telling you, right, whether your disease is progressing or whether it is regressing, which is again useful for an oncologist.
Fascinating. One final question on the science of it before we move to the finances of it, Ashish. In your own press release, you note that Dr. Stephen Abbs, a genomics consultant and former director of the genetics laboratory at Cambridge University, said there's still significant work needed before it can translate into an accepted diagnostic test. A larger study needs to be completed at the earliest opportunity. So, two-part question. One, do you require to do more in terms of the R&D? And two, when you talk about a larger testing population, what sizes will you now need to scale this up to in terms of testing and reconfirming what you found?
Well, since we're talking about all cancers, right, we are actually looking at more like a 10,000, 20,000 patient study, right, which is a large study. And what Stephen was referring to also was that what he would expect is that for such a breakthrough to have international appeal, we need to do Western trials as well, right? So that is actually the next step of the process. We are speaking to global CROs, right? The way this works is that you file your patents, you go public with your story. So you publish. After you've published, right, you will actually look at doing a larger study, right? And that's the stage at which we are at this point in time. So this was only an India study, right? It did not have samples from other countries. So you can imagine that if you're looking at regulatory authorities of Western countries, well, they want to see their own samples in the study, right? And that is part of the process. That's actually what the next step is going to be for us.
I noticed another article where you indicated that you're in talks with investors to raise $200 million to fund large clinical trials. And you're looking at this figure that you indicated, Ashish, of 10 to 20,000 patients, I beg your pardon. It seemed like a really small figure. Is that what you're going to require in terms of the first tranche of investment?
So we will need. So look, the advantage that we have got is that we have made our breakthrough early, right? All our competitors that we are talking about, they're still dealing with the challenge of identifying, having specificity at an early stage. Look, you don't need a blood-based marker to know that you have cancer at the fourth stage, right? And at fourth stage there are many signals, right? What you need it at is at an early stage 1, stage 2. And if you look at all the publications of our competitors, you'll find that their specificity rates are just not high enough, right, for oncologists to actually trust that data, right? What we have actually achieved is that we have already made our breakthrough. We already know what our marker is. We already know how it's working. We know that it is working on all types of cancer. What we now need to do is a large enough study to get regulatory approvals, right, from different countries. So you're absolutely right, by the way, because 200 to 300 million is a very small figure to actually for the kind of claim that we are actually making, right? But I mean, our competitors have already spent billions of dollars, and they're working on certain very expensive processes like methylation technologies, etc., and still not getting the specificity that is required, right? So that is the reason their cost base is so skewed at the higher end, because they're still in product development mode. We've already completed our product development as we see it, right? What we're really doing is a global study to ratify this so that we can launch the service, and that's what differentiates us actually.
What is the size of the market though that you estimate at this point, Ashish? I mean, as you said, for liquid biopsies, I think the market is between 30 to 100 billion dollars. It's huge. Some of the competitors that you allude to themselves enjoy a very large market cap. Diagnostics is a giant business in itself. What is the market potential that
Yeah.
you guys could be looking at over here, realistically speaking?
Look, what we envision is a world where everyone at least above 30 needs to be doing this test once a year, right? And incidentally, you're talking about the liquid biopsy market. I have actually read figures on the cost of this disease, right, to economies, right? And there's data out there that says that the US is impacted by approximately 1.7% of its GDP because of the cost of cancer treatment and the cost to the economy, if you will, right? So there are some very substantial figures that are already out there. The way we see it is that, look, if you can actually, and what we are confident about is that this is perhaps one of the most effective screening tests for cancer, right? For the reasons I've already told you, that it is giving a positive reading for non-cancer, right? Unlike the absence of a cancer reading, right? So that is the fundamental reason why this is actually quite accurate. And the way we see it is that, look, if all of us are doing this once a year, right, we will catch that cancer at stage 1 or before, right, when it is infinitely more treatable, right? And that's an aim that actually really drives us, right, to work harder for what we are trying to achieve here. Our goal is, if we can turn this into an early stage disease rather than a late stage disease, now that's a world that we would be very proud of. It's if you just look at the statistics, there are about 10 million people dying from cancer every year, 800,000 people dying from cancer every year in India alone. And but statistics are one thing. The cost of this to the lives of the patient, their families, the cost to the system, and it wreaks havoc on the social fabric of your society.
Yeah.
So if we can do something about this, now that's motivating.
No, I was just going to say I completely agree with you, Ashish. I think COVID has shown us that statistics are one thing, but personal loss is a whole other part of this tragedy. I understand that you intend to come to India by September or October with test kits. Walk me through what remains in terms of regulatory green lights, and what you've sort of planned out in terms of your first lab, whether you're thinking about how you'd like to price it, because I know you've also indicated you want to keep this as economical as possible. What are you thinking of, on those terms?
So our lab is already under construction. It's our first lab in Bombay. It's opposite, it's going to be in Worli / Lower Parel, if you know the geography of Mumbai. So that's our first lab. We intend to build 3 labs in the first phase. What the reality is that we need to actually speak to the regulatory authorities, because the rules are different for different countries and also different areas of business. So I'm glad you asked this question, because so, a lot of people actually think that we have to go through certain regulatory hurdles that are really required for pharma companies, right? So the fundamental rule when you're actually, in medicine is do no harm, right? When you're actually ingesting a medicine or you're taking a vaccine, you're taking something into the body, right? The authorities are extremely concerned, right, about what are the negative side effects of this. What we are doing is a non-invasive approach where we are literally actually taking a blood sample and providing some very essential data to oncologists, right? Who and Indian oncologists, in our view, are perhaps some of the smartest and most respected oncologists, right, all over the world. And the reality is that what our aim is going to be able to show them what kind of data we can give them, right? And they have a pretty good idea of what are the other detection methodologies and what their downsides may be, right? So they do have options of biopsies, they have options of PET scans, they have options of CT scans, and so on and so forth. They have a pretty good idea of what the limitations of these technologies are, right? And a non-invasive blood test actually has many advantages, right? Because it can be done a lot more frequently than any of these other procedures. And if we can provide that data, I see no reason why we will get the acceptance of the oncologist community. And so, there are, from a regulatory perspective, the reality is I think countries will actually be very supportive, right, including India. But the real challenge is actually getting the acceptance of the oncologist community, and that's that we're going to find out when we launch the service. And we are working very hard to make sure that we launch the service in India before the end of this year itself.
And on pricing?
So, I've been asked this question. I'm not, I'm kind of new to this limelight, but, I, by nature, don't just avoid questions, right? There's a reason why I have not been able to say anything on pricing, because please appreciate that this is a very complex process as well, right? And I can tell you about our ethos, right? We don't intend to price it very high, because we want this to be affordable. There's an emotional reason for us for why we have got so heavily into cancer research. But what we are very keen on is that we want every Indian doing this, right? And because it'll save a lot of lives. And if that is your purpose, then you need to be cognizant of the fact that there's a certain amount of pricing that is, beyond which it'll actually not serve a purpose. Um, and what's more is that we intend to actually keep the pricing the lowest in India. Look, we are very proud of the fact that this breakthrough is actually being made in India, and I can tell you that we want to make sure that it is affordable to all Indians. So we are going to keep it low. As to what exactly that number is going to be, I think it's a little early for us to give you a definitive answer on that. Okay. But we're working on it.
Fair enough. The limelight is new for you, but not for some of your board of investors, including your brother, I think, who's also on that board, Ashish Tripathi. What was the mood amongst the board when they found out? Your brother, of course, but everyone else, because there's a lot of what can I say, blue-blooded wisdom over there, from the medical and the financial.
Look, we come from a pretty humble family, and all of us are. Um, uh, we don't have our heads in the cloud, but what has helped is the fact that Amish is pretty famous, and the reality is that he's been able to help us navigate some of the PR and so on and so forth, which he knows so much more about than probably my elder brother Anish and I, right? But we are all professionals. If you look at our three backgrounds, we've all got expertise in certain areas. We work very, very closely together. My father he's an absolute genius. I mean, at 80, he's still making breakthroughs like this. I mean, the guy is, the man is just an absolute genius. Um, but what has driven us, as you know, is we lost someone very, very important to us in our family because of this disease, and I believe that we've got someone very powerful looking out for us in even higher places, and making sure that we're successful in what we are trying to achieve. Yeah.
That was actually my final question, Ashish, on whether that's the reason you chose to name this the HRC test, and whether that was sort of the catalytic moment for all of you as a family in terms of what you wanted to spend the next few years really diving into and working more deeply on.
So let me put it this way, he played a more important role than even that. To be candid with you, we would not have, we were essentially a molecular medicine company. We personally got into this particular area because we thought that this technology may be of help for Himanshuda, right? And he knew about what I was working on, right? And amongst the most important things that he had mentioned to me was that this disease is actually becoming a disease for the rich. And I mean, what are the poor even supposed to do? If you look at the cost of the treatment, it's I think the world needs to take more responsibility for how much pain and suffering this particular disease causes, and so that's an ethos that actually matters to us. We want to make sure that we have a real and lasting impact on the treatment of these diseases. And of course, there are monetary concerns. We have to actually also be answerable to our investors. But that said, what we do intend to do is actually make sure that we keep the pricing low. And I'm pretty sure that Himanshu Dada is smiling down at our work. And to immortalize that, we wanted to make sure that his name is on the test. So this is called the Himanshu Roy Cancer Test, and that's for short. And I think in one of the interviews, my elder brother made a comment, which is a sentiment of the entire family, that wherever this test goes in the world, we'll make sure that it's still called HRC. That's important to us.
I wish you luck. Congratulations on your breakthrough so far, Ashish. And I agree with you. I think, if anything, the last 2 years should have taught us that to respect scientific temperament, to respect public health, and to respect those that are putting their life and soul into it. My regards to your father as well. Thank you so much for speaking with me today and for sharing all of it that you've learned so far. Thank you.
Thank you so much.
To receive instant updates on all videos from The Wire, click the subscribe button and hit the bell icon. Pay to support independent journalism. Click the link in the description and choose the amount you want to pay.